Hi, everyone. It's officially start time, so we'll go ahead and get started. My name is Kendall Perry, and I'm going to be your host for the session this evening. So first off, welcome. Thank you for joining us on behalf of the Carie-free team. We are excited to continue the tradition of our annual Caries Science Update. As many of you know, we have a strong commitment at Carie-free to stay on the cutting edge of science. Our founder, Dr. Kutsch, and also our presenter tonight, we like to think of him as the world expert on Caries research. He's constantly combing through the current literature, keeps us updated on what's new and what's relevant, and because we know that's important to all of you, that's why you're here tonight. It just wouldn't make sense for us not to share it with you. But before I introduce Dr. Kutsch, let's take care of a few housekeeping items. So for the slides, they will be available to download at the end of the presentation, so please don't worry about taking snapshots of them during. Just sit back, enjoy the content. We will make sure you have access to the slides and cited sources afterwards. And at the end of the presentation, I will let you guys know how to download those. We're scheduled for 60 minutes of content and about 15 minutes of Q&A at the end. I do encourage you to stay on for the entirety of the presentation so you can engage live with Dr. Kutsch. But if it goes long and you have to leave us, we totally understand. You can disconnect at any time. We promise we won't hold it against you. We'll be sending a recording at the end as well, so you'll have the full version to watch later. Speaking of Q&A, we'll be looking for your participation throughout the session, so please don't be shy. There will always be a chat box or a Q&A box somewhere on your screen. I see that a lot of you have found it already, so thank you for chiming in and letting us know where you're coming in from. We may pose some questions to you. We're going to do a poll during the presentation as well, but you're always welcome to type comments, questions. We like to hear from you. It keeps us on our toes. Also, if you have technical difficulties during the session, you can seek help in any of these boxes. We have a team of people here that is willing and ready to help you. So, okay, with that out of the way, it is my pleasure to introduce Dr. Kutsch. I mentioned earlier that he is the founder of Carie-free. Dr. Kutsch also has an impressive resume, and we're lucky to have him as our Canberra expert. He's published hundreds of papers in journals. He acts as a scientific advisor on dental caries for the Kutsch Center. He reviews for multiple journals, including JADA, Compendium, Inside Dentistry. He also still finds some time to practice a few days a week here in Albany, Oregon. I hear that he also finds some time to have some fun in his life as well. So without further ado, Dr. Kutsch, I will let you take it from here.
Thank you, Kendall, and thank you, everybody, for being here tonight. This is kind of a bit of a tradition for us to do an annual science review, and it's one of our best attended webinars that we host, and so I just appreciate you guys taking your time. Every year when we start this, I always think, well, I don't know how much really good science was, done in the last year on dental caries, but I tell you, every year we have. It always surprises me because I spent a lot of time reviewing all of the science, and so we're going to start with that and share that with you tonight here. So we've got some pretty exciting things, and there's a few of these articles you'll actually be able to download as well. And so let's get started. I love this quote, and this is from my good friend and mentor, John Coyce. Information is cheap, or is free, I'm sorry. Knowledge is cheap, but wisdom is priceless. And it's really a matter of taking all of this free information. God, we live in an age where information truly is free, and knowledge is not very expensive. But to put all that together and figure out how to utilize it, how to help your patients where it makes sense, that's really a priceless opportunity for us. So I want to start tonight with a quick survey. How many people are doing caries risk assessment routinely in your dental practice? So that means using a risk assessment form. This is my form. This is the Carie-free form. I don't care what form you use, but just I'd love to have you click in and give us an answer. Let me know. I think I'm I'm sharing with the choir here tonight, but because I know that you wouldn't be on this webinar unless you had some interest in dental caries, or maybe you're doing caries risk assessment just routinely all the time. So I just wanted to kind of start with that and go, let's have a little fun tonight and just see where we're all at. So it looks like pretty much everybody has chimed in here. Kendall?
Yeah, I love all of our attendees because we don't even have to tell them how to work with the platform that we're on. Everybody knows. You just jump right in. That's awesome. It looks like most everyone has voted, so I'm going to end the poll so we can share those results with all of you.
Yep. So it looks like 27% of the people, 28% of the people on tonight do Caries risk assessment the majority of the time. 34% never do it. Welcome. I hope at some point you see the value in doing this at least sometimes. And then we have 38% of the people on tonight are doing it sometimes, just depending upon the patient. And so I commend you all because those are pretty high numbers. And I'll show you some data and some statistics here tonight as we continue on and look at some of the research. So I want to start with just looking at caries globally, and it's the #1 disease in the world. It's #1 in every country in the world, and it's #1 in every demographic in every country in the world. And dental caries just in primary teeth is the 7th most prevalent disease in the world. So we're talking about the #1 disease, and it's a challenge, and it's frustrating. And if it were easy, it wouldn't be the #1 disease in the world. We'd have knocked it off and cured it, and we'd be talking about something else tonight. So that's a challenge for us. And one of the things particularly that's been a challenge here in the U.S., the CDC reports every 4 years on caries incidence, primarily in our adolescents, so 0 to 17-year-olds. And I got to tell you, for the last 30 years, I've been watching this climb like almost double digits every 4-year reporting period. And I'm excited to share this with you tonight because for the first time in my memory, since 1990 when I started looking at this stuff, we actually have a slight decrease in untreated caries and total caries prevalence in our adolescents. It's not huge, but it's a step in the right direction. My concern here on this is it might just be a blip, but I'm hoping that this represents the work that all of us are doing in the profession to try and get better at how we treat this disease, and and just better awareness from our patients as well. But just know that for the first time we can talk about we've actually put a dent in this disease. So it's actually going down slightly. When we start looking at the disease itself, I've talked about the last 4 years. Candida albicans is kind of the big story in dental caries. And, we know it's a biofilm disease. We know that it's an ecological issue in that biofilm and a behavior of the biofilm itself, and that we have both all kinds of microbes in addition to bacteria. But Candida, about 4 years ago, was starting to be identified as a pretty prominent player in this disease, and I would share with you that Candida is extremely acid uric as well. So those patients that have candidiasis, your older patients that have candidiasis, have burning mouth syndrome, some of that can be from Candida, and it's difficult to kill. So this is a real challenge, and it looks like it plays a big role. So in this study I'm sharing with you right here, there were 39 children. 21 of them had severe early childhood caries. 18 of them were caries-free. There were 33 mothers, 17 of which had a high caries risk, and 16 of which were caries-free. And then they did basically, DNA checkerboarding on them to see, what kind of correlation of what was happening. And the interesting thing is, Candida increases the acidogenicity and acid uricity of the community of the biofilm, and it increases bacteria like mutans, streptococci, and lactobacillus, Scardovia, which we'll talk about in just a minute. But here was the part of this study that I found that was most interesting. It increases the glucosyltransferase activity. And you remember that enzyme in the mouth is responsible for helping break down and metabolize carbohydrates like glucose. And so that's being able to not just be there and creating a more acid uric environment, which then would select for those acid uric bacteria that we just shared, but it also increases the enzyme activity. So I thought that was really interesting. The other interesting thing from the study is that, once again, we find that the child and the mothers, they could identify them based on the DNA samples that they took. So they shared the same biofilm. So we've known for a long time that mom is is a huge predictor in terms of caries risk, or let's say primary caregiver, but usually that's the mom, is a huge risk for dental caries for the child. Another interesting thing that came out of this study was that looking at both the plaque itself and in the saliva, it really broke into 4 groups of, and we talked about that before, and we'll talk about it again in a second, but the children broke into kind of like 4 groups based on the biofilms in their mouth. And so human beings like to look for patterns. I mean, that's just part of our existence. We're always looking for patterns. But to see a group like this, we know that certain microbes prefer living next door to each other, but it appears to be that there may be kind of groups of biofilms. They may break roughly into, like, your biofilm in your mouth is roughly a part of one of these groups. And this was a study that was published this last year as well, and it looked at adolescents, and this came out of Sweden, and they were looking at 17-year-olds and looking at those patients that were high risk or low risk for dental caries. They either had mutans streptococci or they had none. And so you ended up with these clusters of 4 groups of these adolescents that, had mutans streptococci and were high risk for dental caries, had mutans streptococci, were not high risk for dental caries, and then you had the groups that they had no mutans streptococci, and they still were high risk for dental caries. And in most of those patients, of course, we saw Scardovia wigsii, which was identified by Ann Tannerback, I think, in 2011 as a potential pathogen for this disease. And so you had patients that had, like Scardovia wigsii, kind of took up that space that was traditionally we think of inhabited by mutans streptococci. So we know that about 40% of our adolescents in the United States have no mutans streptococci, even the ones that have severe early childhood caries. So I've talked about this before, but again, looking at this is truly an ecological biofilm dysfunction. If this was just a single pathogen, or if mutans streptococci was the pathogen that we've all kind of blamed for forever here, it wouldn't look like that. So 40% of these high-risk kids don't even have that bacteria in their mouth. So, but then they do have things like Scardovia wigsii or Slackia exigua. But it's interesting to look at these start to break into clusters, and it just, not that we can do anything with that information right now, but I think it's interesting from the standpoint of it's giving us a little more data on how these biofilms behave and how they develop and which bacteria are found in different biofilms. Now, of course, there were 2 papers in the last year, one that said basically we don't even know what role mutans streptococci plays at this point in time because it doesn't really look like it's that significant of a player. And then this paper said, well, it's consistent. The data that we have remains consistent with the prominent role for mutans streptococci in caries development, especially those who experience the disease at its worst. So the people who have that are most at risk or have the worst expression of the disease seems to play, mutans streptococci plays an important role in their biofilms. But again, I would just caution you, a word of caution there, just this is not a simple disease, because you just got to keep remembering 40% of the people that have it don't even have that organism in their mouth. So it still calls into question, our disease model. I think we're best looking at that, the Philip Marsh, Takahashi Nevad, concept of the ecological plaque hypotheses. I included this study. I thought it was interesting. We look at how the bacteria, and we've been looking quite a lot the last few years about how the bacteria in the mouth affect the rest of the body, and I'll share a couple of those studies tonight that came out in the last year. But so we tend to think of like, well, what effect does it have on dental, on the rest of the body or overall systemic health? It's interesting in this study, the cognitive impairment that individuals had increase their risk for dental caries. And if you think about it, that kind of makes sense, because then maybe they forget to brush their teeth, or maybe they don't brush their teeth at all, or maybe their impairment doesn't allow them to be as efficient at brushing their teeth or flossing as they were at one point in time. And maybe given their own, left up to their own devices, maybe their diet isn't as healthy as it could be. So it's just important for us, and I know you guys deal with this every day in your practice. You've got the patients that that are impaired, the senior patients, and it's a challenge and a struggle. What do you want to do for these people? Are you going to extract all their teeth when they're 96 years old and put them in a set of immediate dentures? Or are you going to use silver diamine fluoride and just try and hold the wolf away from the door for a few years? That's a real challenge, and it's a conversation for us to have with the families. But I have that challenge in my practice, and it is truly, it's heartbreaking at times, and I know that you guys deal with the same thing. But so we know cognitive impairment can increase the risk for their dental caries, and that certainly becomes a challenge. On this study, which was published this last year, it looked at the fact, and we've talked about this before, that the strep mutans that has the CNM gene allows them to directly invade an endothelial cell. And in this study, they compared looking at cardioembolic infarct, brain hemorrhage, microbleeds in the brain, and found that there was no relationship between the CNM positive and other known risk factors. So the conclusion of this study was that this strongly suggests that the CNM mutant streptococci are and I've seen other studies that concluded that we're responsible for, but that may play a major role in microbleeds in the brain and maybe perhaps strokes. So that's something that we all need to be aware of. Now, the next question that's asked, and it wasn't answered in the study because they looked at all of these other risk factors for these strokes and bleeds, like diabetes and obesity and hypertension and heart disease and smoking, and you go through all these other risk factors, and they didn't correlate with the microbleeds. But the challenge that they didn't look at, and that's what this paper brought to the attention, is okay. So now we know that these strep mutans appear to be playing a pretty significant role in the brain in terms of microbleeding and strokes. What was the DMFT scores of these patients? Was there a relationship between their cavity risk or their caries risk and their risk for stroke? And, so they haven't made that connection yet, and that really needs to be studied. While they looked at all these other risk factors, they didn't contemplate, which I don't know why. I mean, maybe because they're not dentists, but we as dentists, the first question we'd ask is like, well, how many cavities did the patient have? How much mutant streptococci was present in the mouth? And does that correlate to the microbleeds in the brain? So that question remains unanswered. So I think it'll be interesting. I mean, I don't know the answer to that question. I tend to think that we know that other oral pathogens, when they're found in high numbers in the mouth, tend to find their way into other arteries and stuff in the body, heart valves, coronary arteries, etc. And we know that a lot of peripheral inflammation may be caused by or may be contributed to by oral pathogens, particularly, we've examined the periodontal pathogens. But I think this is an interesting question, and I hope that we see more data on in the future. Anyway, I just wanted to share that with you tonight. I'm sharing this study with you because this just came out, and I thought it was interesting. It doesn't have anything to do with dental caries, but again, talking about that oral systemic connection, it appears that Fusobacterium nucleatum kind of facilitates colon cancer, like it makes it worse and more aggressive. So again, we're seeing, we've looked at all of these other bacteria, Porphyromonas gingivalis, and the Alzheimer's brains. I know, I'm sure you guys saw that study about a month ago. But so looking at these oral pathogens and what impact they may have in other parts of the body, I think, and it's really important. And it's really important for us to kind of have a consideration of that and maybe start having those conversations, if you're not already, with your patients. You've got a lot of disease in your mouth, and my concern is not just your teeth and your gums, but maybe what those same bacteria might be doing in, bad things they might be doing in other parts of your body. And Brad Bales and Amy Deneen kind of like to think of dentists and hygienists as arteriologists, because we're working to fight the inflammation that causes or contributes to inflammation in our vascular system. So I just wanted to present this to you. I thought it was interesting. I know that we've looked at and talked about genetic risk, and we know the genetic risk for dental caries in a population, looking at a population level is about 9%, and we've identified 35 plus genes at this point in time that we know play a role in dental caries, primarily ones that make you more susceptible to dental caries. I thought this study was interesting because they looked at DMFT scores and they collected them. So this was a longitudinal study, age 5 through 18, from 876 adolescents. And what they found was that the kallikrein 4 gene actually appeared to be associated with a decreased risk in dental caries. So, there are genes that put you more at risk, and there are genes that appear to put you less at risk. And I like the fact that this was a longitudinal study. So when we asked earlier about how many people, so we did a little survey here amongst ourselves, how many people are doing caries risk assessment kind of routinely or sometimes or never. This was a paper that also looked at that entire topic and had done a survey and was published based on using a risk assessment form, and found out that 14% of dentists in the survey indicated that they use a caries risk assessment in their practice. Now, it didn't really break it down into, did they use it like on every patient once a year routinely, or were they just using it kind of sometimes? But only 14%, and I would tell you based on when I'm out speaking at meetings and I want a show of hands when I start each program, I would say that's an optimistic number. I'm not sure that 14% of the dentists in the United States are routinely using a caries risk assessment in their practice. So that's an area that we as a profession need to put some work into. And the challenges to doing this are lack of patient transparency. Patients lie. We know that patients lie. They know the right answer. We ask yes and no answers. Do you floss? We ask the wrong questions, and they know the answers to those questions. And sometimes or maybe they're just confused and they don't think of antihistamines and antibiotics as medications when you ask about dry mouth. You run into a lot of different scenarios, but it's sometimes challenging to get accurate information out of a patient. It takes more time. It does take more time. And then we haven't been trained to talk this way. I mean, we've been trained to identify how many cavities you have and tell you what kind of fillings and crowns you need. And, we're real good at that, and we're real comfortable telling somebody what they need on their teeth, or they need 4 quadrants of root planing. But in terms of talking and starting to ask open-ended questions, tell me about this, tell me about that, tell me about your diet, describe an average day for you, describe your home care habits to me. We weren't taught that kind of like wellness coaching language. So that's a challenge for us. So something, again, I think that there's certainly an opportunity for us to all get better at our communication skills. And then there's lack of reimbursement. I mean, we don't yet have universal reimbursement for codes. We have the codes, but we don't always have good coverage for those codes that relate to caries risk assessment. So all of those things make this a big challenge. But anybody that's doing this certainly understands that once a patient understands their disease and can get healthy, ironically, you'll be doing more large restorative cases than you've probably ever done in your career. If we look at fluoride, I'll look at the studies, some fluoride for the last year. Remineralizing therapy, neither the fluoride rinses nor phosphopeptide toothpaste, the CPP-ACP, with or without fluoride, had any positive effect in addition to, this was a systematic review, in addition to just 1,100 part per million fluoride toothpaste. However, a 5% sodium fluoride varnish was the only therapy to show a statistically significant improvement compared to the control group. So I know we've talked about fluoride varnish a lot in the past. I think this is standard of practice. I think you're all doing this. And certainly it's something that we know works, whether the fluoride rinses and the CPP, ACP, whether or not they're helping in remineralization or not. The fluoride rinses may help with caries prevention, but in terms of remineralization, didn't show any results really over a good 1,100 part per million dentifrice. However, fluoride varnish was a key. And then if we look at dental quality assessment and oral health assessment and start to look at pit and fissure sealants like assessing the validity of existing dental sealants and how we measure whether they're working or not. The interesting thing that came out of this study was that we're only utilizing sealants on at-risk teeth at about 18.5%. So about 1 out of 5 teeth that could benefit from having a pit and fissure sealant, only about 1 in 5 are actually getting sealed. So that's kind of discouraging, but again, if you're doing this routinely, give yourself a pat on the back, because sealants do work, they do help, they have to be maintained. I want to qualify that because we've all seen the sealant bombs in our career. So again, just looking at sealant use, and then this is a topic that's the goalposts are moving. And so I wanted to share this with you because I've seen a couple of lawsuits now, one in the state of California, another in Idaho, and when to restore these teeth. Because if you look at the radiograph on the left, when I was in school, you looked for those lesions on 12 and 13 there. You look for those lesions for your board exam. I mean, and then you went in and did these GB Black, amalgam cavity preparation. That's how old I am. But we looked at restoring these teeth, and if you look at the photograph on the right, you can see the penetration through the enamel into the dent, and you've got the discoloration on the marginal ridge there on the distal of 12. And on the distal of 13, you don't see any of that. So 13 is really an E1 lesion. It's only halfway through the enamel. Those are not cavitated. In fact, until it gets to a D1 level where it's penetrated to the dentin on the left with the red circle, 85% of those can probably be remineralized because they haven't cavitated on the surface. Now, you can't tell that from a radiograph, and you can't tell that from looking in the mouth, but somewhere, until it penetrates the DEJ, you've got an opportunity for that patient to remineralize that lesion, and that's the appropriate step, and we should all be doing that. Now, the challenge for us is number one, patient compliance. Number two, when are you going to see the patient again? And then this is the one thing that I think, in my mind, always gets left out of this discussion in these recommendations, and that's what's the patient's caries risk, right? Because if I'm looking at that lesion, that DO on 12, and this patient's 90 years old, and this lesion is unchanged in the last 80 years, and they're low caries risk, I'm not going to get too concerned about that. If that's, however, a 17-year-old and they're high caries risk and they have other lesions throughout their mouth, and oh, by the way, too, they're leaving to go away to college for 4 years, and I don't know when I'm going to see them again, now that's a different scenario. And so you can't just take these lesions and radiographs and go, okay, fill that, don't fill that. You got to examine the patient's caries risk. That's part of the equation. I can't separate that from your diagnosis. So it should be appropriately part of that conversation. But I just want to make you aware of this is a change. These recommendations are coming from the ADA Council on Scientific Affairs. I know almost everybody on that committee. I consider them friends and colleagues and mentors. And I would tell you that I think their recommendations hit home. So I just want you all to be aware of and not get into trouble by over-restoring teeth that maybe we should try to remineralize first. And so, again, this is a paper from Peter Reckman and John Featherstone down at UCSF. And again, in this paper, the clinical evidence shows that non-cavitated lesions can be remineralized. I'm not going to guarantee they will be remineralized. Again, you're going to have some patient participation in that equation. But if you got a patient that is willing and sincere about doing this, it's totally possible for them to remineralize those lesions. And now that lesion may not disappear radiographically, but it's not going to change over a period of time. And if you want, you can do things like put an orthodontic separator in, have the patient wear it for a week, and actually get them back. I know he and Noah suggested this to me like 20 years ago, and take a polyvinyl siloxane impression in that, and pull the separator out, and then take a look at your impression and see whether there's a bump or there's a hole on the surface of that interproximal surface or not. So, I mean, things can be done. I'm not sure how many of my patients would be happy to wear orthodontic separators for a week, because those things are probably the most painful part of orthodontics. just to determine whether it was cavitated or not, but I think that there are other options for us that we can look at. So I just wanted to share that with you, but we should be trying to remineralize any lesion that we can. By the time it gets to D2, which is 2/3 of the way through the dentin, those are all pretty much all cavitated, and you better be restoring them. By the time you get to D3, like you're flirting with a root canal. So somewhere in the dentin, you need to make a decision based on the patient's caries risk when you're going to restore. This was a paper by Nebad that was published this last year, and then it gets into this whole conversation of not only do we have a caries lesion, but is it active or inactive? Like he's starting to break this down in this decision tree. If it's inactive, you don't have to do anything. And the question becomes, other than just brush daily with fluoride toothpaste, the question is, how do you know if it's active or not, right? And is our metric a radiograph to see whether it's progressing? I mean, I guess that's our metric, right? And then if it's active, is it cleansable? Is it something that you can clean? The patient can get a toothbrush and bristle and toothpaste on. If they can keep it clean, you don't need to necessarily restore it. And if it's not cleansable, then you need to do a restoration on it. But starting to look at, consider not only are we just looking at lesions statically on a radiograph, but what's the activity of that lesion? And I think obviously that makes sense. And again, I would throw in, and what was the patient's caries risk as well. And in this paper then, he had examples that he presented. And on the left, the 4 photographs on the left are examples of lesions that don't need to be restored. They're white spot lesions that are not cavitated. They're occlusal surfaces that clearly have not penetrated the dentin. On the right side of the screen, you've got the active lesions that are inoperable, cleansable and uncleansable. Now, I got to take you to this one because I look at this. I mean, we have to evaluate our science, but on the bottom right-hand corner, you've got this molar that 2/3 of it is gone. Okay, so it's an active lesion, but it's cleansable. So it doesn't necessarily need to be restored. I'm assuming everybody's sitting there thinking, huh? Yeah, you'll see patients come in with teeth that look like this that have been broken for 20 years, and they've kept it clean. But my concern here is a biomechanical risk of the rest of that tooth breaking off and losing it. Like the restoration here maybe isn't necessarily for dental caries, but it might be to restore the function and protect the rest of that tooth so that you don't end up losing it. Biomechanically, maybe not necessarily from dental caries. I just wanted to point those out, so I think we're all pretty much on the same page there. Then I want to share, and by the way, this paper is one of the papers that you can download. This came from Rella Christensen, and Rella, I think the world of. She's been a mentor to me and a friend for almost 30 years, and she comes up with some pretty interesting thoughts and challenges, and I appreciate, Rella from a scientific standpoint. She's been doing a lot of work in the last 4 years looking at microbes inside of lesions, and arrested lesions and active lesions, etc. And then looking at tooth preparation and how we disinfect, or rather don't disinfect, our cavity preparations prior to restoring them. And basically in my conversation with Rella is she at this point in time doesn't believe that there is a such thing as an arrested lesion. They literally found viable bacteria in every lesion at every depth. And so these things appear to be hard, solid, non-cavitated. And so the question becomes, that's a challenge for us all. Okay, so there's viable bacteria in there. What does that mean and what we do with it? And her concern about our lack of disinfection of restorations before we restore the teeth or place a restoration is lack of isolation, using the same burr, maybe inoculating the deeper dentin, leaving infected tissue in the preparation. We're using air water units that we know are not sterile, and then not disinfecting the preparation properly. Her protocol for disinfecting properly, and I'll go through this, but I got to tell you, her protocol is after you acid etch your cavity preparation, wash with water and damp dry. Then take 1 to 2 drops of Gluma and take a fresh, clean brush. Now this is an isolated tooth, and just allow it, saturate it, allow it 1 minute of contact time. Then do not blow air or dry. You just want to suction it dry with your suction, or suction it damp. And then with a fresh brush and a fresh couple of drops of Gluma, repeat that process so you've got a new clean brush again and new Gluma, and saturate it again for another minute, and then suction it damp dry, and then go ahead and restore the tooth. Based on our normal restorative technique in disinfection, you see what happens in the Petri dish on A, and following this protocol, this is what it looks like, when they look for a bacterial sample in that cavity preparation. There was not a single colony growing. So, depending upon what your attitude is or philosophy on this is, here is a protocol that I can share with you that will produce a cavity preparation that is not contaminated. It looks like B. Now, the challenge that we have is, the question I ask is, so what's the clinical outcome? How does that, what bearing, because I'm using silver diamine fluoride, and I've had some sidebar conversations with Rella on silver diamine fluoride. I've got some new information to share with you on that tonight as well. But this study, this was a random controlled trial that was done in terms of taking out the deep carious lesion, and rather than taking it all out, and we've seen these studies before, but this again gets the same outcome. Are you better to leave a little decay and then restore over the top of it in terms of viability of the nerve, or are you better off to take it all out and then restore that? And the 12-month success, the clinical outcome, now this is short, it's only 12 months, but the clinical outcome at 12 months was 4 times higher. The reversible pulpitis, survival of the pulp, was 4 times higher in the self-limiting protocol, where you left some decay behind and then restored over the top of it, than compared to taking it all out. And molars were better at that than premolars, and probably because you had, just a greater amount of distance between the dentin, or the advancement of the lesion, and the pulp tissue itself. But just, these are two conflicting data points. Rella says there's no such thing as an arrested lesion. We should be restoring everything with care, and we should be disinfecting it very carefully. And then here's a paper that says, well, if you want the best outcome, leave some of the decay behind and restore over it. So I don't have an answer for you, but we're fair and balanced, and I think we need to look at all of our science, and then you need to make a clinical decision. I'm going to do this or that, based on your belief and trying to wade through the science. So I know that I've been doing this for a lot of years in terms of these deeper lesions, getting down to leathery dent, getting down to some dent, and when you get to that discoloration, that's the point. The brown, or if it's even black in those areas, tend to be not as active. So then I tend to start to restore there, leaving that to insulate between my restoration and the pulp tissue. So I'm leaving you with those two conflicting studies, but I think it's important for us to consider both of them. So then the Council on Scientific Affairs from the ADA came up with recommendations for what do we do non-restoratively. So if we're going to take a look at these non-cavitated, active, cleansable, or non-active lesions, what do we do with them? These interproximal E1, E2 lesions, rather than restoring them, what should we be doing? What kind of recommendations do we have that are non-restorative therapy? And these are the recommendations that they came up with. Of course, obviously looking at specific lesion type, the tooth surface, and the dentition itself, of the most effective interventions, and this was, again, a systematic review. And recommendation on a testimony of experts, use of silver diamine fluoride, sealants, 5% sodium fluoride varnish, acidulated phosphate fluoride gel, 5,000 part per million fluoride toothpaste or gel were the best recommendations from the panel. It also provided a specific recommendation against the use of 10% CPP, ACP, either with or without fluoride, as it not being a remineralization recommendation. So I want you to be aware of that. So those were the guidelines from the ADA. And this was a study then that was published from another group of authors, and this was published in the Journal of Dental Research in January of this year, and again looked at the same thing and said what kind of, and again a systematic review looking at papers, what kind of non-restorative therapies make sense and are effective in treating some of these lesions. And what they came up with, 48 studies, 7,300 participants, 22 different interventions, and here was the 4 that they came up with: sealants, fluoride varnish, 5,000 part per million fluoride gel, and silver diamine fluoride. So those are 4 that are consistent with the 4 from the Council of Scientific Affairs. So I think these are probably should make up the core of your regimen in terms of non-restorative treatment recommendations. Now, to go a little further, this was published in General Dentistry in November, December, the issue, looking again at evidence care for non-restorative therapies for early childhood caries and chronic management of disease in kids. And again, look at the modalities they recommend: fluoride varnish, silver diamine fluoride, interim therapeutic restorations, certainly like glass ionomer, GIC, and sealants. So again, we're looking at pretty much the same. Again, you might put this kid either on a 11 part per million fluoride, or depending upon how old they are, if they're past the age of 6, depending upon their risk, you might put them on a 5,000 part per million gel. So again, we're pretty consistent. 3 different references here in the last year are all recommending the same kind of guidelines and therapies for remineralization of these teeth. I hope that makes you feel better and gives you some point of reference there. One of the challenges, oh man, and I was just at the Oregon Dental Conference this weekend, and I've been on the conference committee on and off for almost 16 years. We have a great meeting. I take great pride in our Oregon Dental Conference meeting and all of the people that make it possible, because it's a work from a lot of people, and I'm proud to be a part of that. I was standing next to the Carie-free booth during a break, and one of the people who worked for the host staff, at the convention center, came up and asked the question, well, how do you feel about fluoride in the water? And I still, and she was just itching for a fight, right? I mean, you see people that she just wanted to have a fight over the fluoride in the water, and I thought, this is like why I signed off of Facebook 2 years ago. You don't win an argument with somebody on Facebook. That's a debate on Facebook. It's a grand waste of time. And so I just stood back and I go, well, a lot of people, there's a lot of different opinions and everybody has one. And, well, what's yours? Well, how do you feel about this? And he said, you know what? I have an open mind. And, what's your opinion? And then I walked away. And I thanked her. But it's like, you're not going to win a fight. I live in the People's Republic of Oregon. They want to take the fluoride out of the water. And I got to tell you, there's been a lot of valid questions asked in the last 20 years, because we have so much fluoride varnish, silver diamine fluoride, fluoride in our toothpaste, fluoride in our gel, fluoride rinses. There's no shortage of fluoride in terms of patients' access to fluoride. And the question that's been asked, and I think it's a legitimate question, is almost all the studies that were done on fluoride were done, fluoridated water, were done back in the 1965 to 1970, 72, when there wasn't the widespread use of fluoride in dental practices and in dentifrices, et cetera. And so since we have made that change as a society, is it still relevant to put fluoride in the water? Is it still helpful, in addition to all of this other stuff? And the CDC, released this report. This came out in the Journal of Dental Research in September. Based on evidence, appears to community fluoridated water appears to prevent 30% of cavities per year. The reduction is 30% per year in primary teeth, and it's 12% per year in permanent teeth. So there's still a valid reason that we should have fluoride in our water, and we're still getting a 30% reduction in decay is significant. So my opinion on this is yes. Anybody wants to have a debate with me on that, I've got my opinion. You've got yours, and I respect your opinion. This is another interesting report. Now, Juneau, a number of years ago, Juneau, Alaska, took the fluoride out of their water. Calgary, Canada did this, and you look at the results, and this is interesting. I told you that it appeared to decrease the number of cavities by 30% based on our data here in the U.S. When they took the water out, or the fluoride out of the water, and they looked again from 8-year-olds, or 0 to 18-year-olds, and then children that were 7 and younger, because the water had been, they'd taken the fluoride out of the water for 7 years. What they found was that patients in the non-fluoridated water group had 35% more cavities than when the water was fluoridated. And the increase in cost was between 28 and 111%. And the worst caries risk was found in the kids who were born after the fluoride had been removed. So in that 0 to age 7 group, they had the worst decay rates. They'd had no lifetime exposure to fluoridated water, none at all. So the data is pretty clear, you know, and I'm giving you the data points. And from there, again, we all have to make a decision on whether you think that's a good idea or a bad idea. This is a study that looked at mouthwashes, antiseptic mouthwashes, and the thing that they looked at, Cepacol, Colgate Plaque, Listerine, Oral-B Complete, and Sensodyne. And the thing that was consistent in the study, they were pretty effective against most of the bacteria. However, they were not so effective on Candida albicans, and as we talked about earlier tonight, appears to be a major player in dental caries. And then they also had significant cytotoxic effects on the gingival fibroblasts. So are these medicated mouth rinses, antiseptic mouth rinses, are they appropriate or not? I'll leave that in your court. Here's a study that I think provided some interesting data. This is Philip Marsh, and this was a paper Philip published a year ago, basically. And again, talking about how do we treat this disease, and of course he's the one that published all of the science back in the late 1980s, 87, 88, and 1990, that evaluated the selection pressure and determined that it was actually the pH in the biofilm of the mouth that was causing the selection for the wrong bacteria, and then the behavior. And if we want to really modify and mitigate that risk, modify this disease for patients, we really need to look at manipulating and changing the pH in the mouth so that we can get a patient back to health. And so this was just another paper from Phil, modify the pH. One of the things that we use at Carie-Free is nanoparticles of hydroxyapatite. And this was a study that, again, looked at nano-HA and compared it straight up on demineralization and on enamel, on artificial lesions in vitro, and compared it to fluoride, and it was equally as effective as fluoride. So again, you know, for patients that are fluoride resistant to fluoride of any product, I think certainly look for a nano-HA. The studies are pretty consistent on that over the last 4 years. The nano-HA is at least as good as, if not better than fluoride in terms of remineralization. And quite frankly, that's how your body, that's what's in your saliva, that's how your body does it. So this was a study I thought was interesting. They actually had nano-HA in a mouth rinse and compared it to fluoride mouth rinses, sodium fluoride mouth rinses, and they both enhanced remineralization and increased tooth microhardness. So again, it was equal to. Now, one of the questions you may get asked, because I've been asked this question a number of times, I'll have patients or moms that will say, I don't want any nanoparticles. Nanoparticles are hazardous, and they've read about the nanoparticles of melanine that was found in the milk that was being imported from China, and children were ended up with internal bleeding from these sharp nanoparticles, etc. And so nanoparticles are like toxic. Well, your saliva is super saturated with nanoparticles of hydroxyapatite, and so if it were toxic and going to kill us, we'd all been dead a long time ago. But it's actually how nature developed a process to protect and remineralize our teeth. And so that's how nature does it. Nature uses nano-HA. That's what's happening in your mouth right now and in everybody's mouths right now. And so this was a study that was actually done looking to put nano-HA in oral health care products. And these were safety studies that were done in Europe to get their approval for health, efficacy, and safety. And they actually used gingival fibroblasts, gingival epithelium, as the test tissue, and determined that you can see the histology on the left, negative control and positive control on the right. There was no effect from the nano-HA. And why would you expect that? Your mouth is already super saturated with that, 24/7. So anyway, it is safe, and if somebody needs to read a study, certainly there's one that you can recommend to a patient. Generally, when I offer a scientific study for a patient to read, that typically kind of ends the conversation. It's like, no, okay, I trust you, I believe you. Silver diamine fluoride, still a hot topic. This is Jeremy Horst's paper, and I think certainly recognizes one of the, if not the leading expert on this in terms of clinical and research use. And one of the questions has been, well, how does it work? So we're putting the silver diamine fluoride on people's teeth, how does it work? There's a couple of theories. Number one is that the fluoride hardens the surface, and we know the silver oxidizes, and so it turns those areas black. But Jeremy actually demonstrated that the silver actually precipitates into little microwires down inside of the dental tubules, and those microwires, again, we know that silver is an antimicrobial ion, and maybe that's partly responsible for both the immediate hardness on the surface of these lesions after you treat them, and number two, why you get some antibacterial activity, long term. So that's kind of those are the two theories. This is a paper that came out in JADA last year as a systematic review, and again, I know you guys are probably all doing this, but yearly application of silver diamine fluoride on exposed root surfaces of older adults, simple, inexpensive, and effective way of preventing caries, ignition, and also progression of these. And I know I use it for that, and I'm sure that some of you do as well. I wanted to present this case to you because I think it's really significant. It's kind of the extreme of where we can go with this material. But this was Doug Young and Alan Wong at UOP, and here was a young woman, I think she was 21. This was published in JADA, by the way, in August. But here's a woman, she was 21 years old, a Sjogren's patient, which is pretty early for a diagnosis of Sjogren's. Her teeth were so sensitive that she couldn't brush them. And of course, you see this, you look at her mouth, and she had been diagnosed and recommended to have all of her teeth extracted. Now, she didn't have any bone loss, no periodontal disease. This is just strictly a result of her Sjogren's and, caries risk. And to have all her teeth extracted and have full dentures. And she's like, early 20s. And so what this team did was they treated her with silver diamine fluoride, and it does turn things black, and so you've got to have an understanding of what that looks like. But then all they did was after these teeth, they'd restored them, they treated them with SDF, they went and restored them with GIC. Now, nope, it's not going to win awards at the AACD for cosmetic dentistry, but I got to tell you, I think this is one of the most impactful cases I've seen, and my hat's off to them. Here's a young woman who still has her teeth, and those are not denture teeth, and maybe she has a chance now. She can brush. She's at least got a chance, and before she didn't have any chance at all. So I think that it's an extreme use, but I think it gives you an idea of maybe what's possible, and I think they did a tremendous job helping that patient. This was a study that was published last year in the Journal of Dental Research again, and the questionnaire was, what are all the complications, and bad effects from using silver diamine fluoride, and the only one that came out was just that it turns the lesion black. And I think, so this is what it looks like. I mean, it turns that spot black. It goes from brown to black. And I have that conversation with parents. And, yep, is that black spot better than what if this child had to be taken to an OR and put under anesthesia to be able to restore that? Is that black spot for a few years on a baby tooth better than the mortality and morbidity of running a risk with the anesthesia? And we lose children almost every year to anesthesia undergoing dental procedures. So that's something that's always in the back of my mind. I think this is an opportunity. It doesn't taste good. And the other complaint, if you get it on the gingival tissue, you may see some discoloration on gingiva, typically that's gone in about 3 to 4 days. So those are the only adverse effects of using silver diamine fluoride. This is a paper that came in Compendium. This is a roundtable I participated in. This is one of my patients. He's on his 3rd bout of cancer. At one time, his teeth, matched all those crowns that he has in there. And at this point in time, I'm just trying to keep the fire out, right? I mean, this guy has been through hell, and I'm just trying to, keep him from having to have a lot of dentistry, just keep my fingers in the dike. So it has a significant impact. Now, this study was just published. This one's hot off the press, and I wanted to share this with you tonight. And again, looking at 9 clinical trials, silver diamine fluoride appeared to prevent 61% of new lesions compared to controls. The thing that I thought was significant was again, this is Jeremy. It appears that it's more effective on enamel lesions than it is dentin, and I have gone back to restore some large lesions where they were rock hard and black on the outside, and we still have that really soft dentin deep on the inside. And the other thing is it has the potential to stain immature enamel on erupting teeth, and so I just wanted you to be aware of that. I'm like, this was the first report I'd seen of that, and so I thought, well, that's something that everybody needs to be aware of. So just file that one away. You may need to have that conversation with the patient as well. Diet, again, we know that diet is one of the major players, risk factors for dental caries. It's one of my usual suspects. It's like number 2, and actually it might be higher than number 2 if we could actually get an accurate assessment of somebody's diet in terms of how much sugar that they're eating. So that we know that the diet plays a role. It plays a role in the body. It plays a role in our systemic health as well. We should be eating whole foods, fresh produce, and lean meat, salmon, etc. Rather than, and if it comes in a box or a can, we should be eating things that you get in the periphery of the grocery store. Anyway, so I wanted to share that with you. I had to laugh when I read the study last August. It was in the Journal of Dental Research, and it was really an interesting study. And the headline was, guidelines and effects of starch on oral health. And I thought, oh, well, starch are, complex carbohydrates, so starch. This will be interesting. I want to know, what impact that has on oral health and dental caries. And so they looked at 2 different starches. They looked at rapidly digestible starch and slowly digestible starches. And I thought, rapidly digestible starch, I'd never heard that term. I wonder what that is. So I'm reading the article. Rapidly digestible starch is sugar. And so as we've tried to, the sugar lobby has tried to get the FDA to approve just the use of corn syrup rather than high fructose corn syrup. We're trying to get to change the names on stuff. Wouldn't surprise me to see them try and call sugar on the label as a rapidly digestible starch, because starch doesn't sound bad. I mean, it sounds like a complex thing that's not going to cause cavities necessarily, right? Complex carbohydrates, but we're talking about a rapidly digestible starch, and otherwise known as sugar. So I just want to share, if you hear that term, at least know what we're talking about. I'm including this one. This is really about erosion, but we talk about bottled water. Bottled water, half the bottled waters have a pH of 4.0, again, which is below that threshold for demineralization of enamel and dentin. I just want you to look at this real quick. Alkalife 10 is a bottled water that has a pH of 10. And if you just add one of these water enhancers, the drops, these little packets of dry powder or the little liquids that they sell in the grocery store to flavor your water, if you have a water enhancer, they're very acidic, and it dropped the Alkalife pH from 10 down to 3. So our patients are using these things. So when you're talking about, well, do you drink water? Yes. Are you adding anything to it? That's a new question. Are you adding a water enhancer? Because you go to the grocery store and there's a whole aisle of these things, a whole shelf of these things now. So water enhancers equal dental erosion, and they also put you at risk, for modifying that pH in the mouth in the wrong direction. This was bariatric surgery, and I thought this was an interesting study, and I brought it because, of course, one of the things that we see is a lot of these patients regain all their weight over time. And I know several people that have been through this, and at the same point in time, it increases their risk for dental caries. And the mechanism for that is after having the surgery, they report high sucrose intake, and 59% prefer sweetened beverages and foods with sucrose. So that you change the diet, and you put more sugar, more rapidly digestible starches in their diet, and then you increase their risk for tooth decay. This is one of the last studies I want to share with you. This is Bob Macario. Ran into him in Chicago, and we started talking about this, and he was actually just had this published. And talking about rebranding, like we talk about gum disease, we talk about periodontal disease, and patients think, oh yeah, okay, I've always had gum disease. Oh yeah, I have, it's all about the gums. And with what we know now about the oral, systemic connection, we really need to rebrand, and he started with periodontal disease, to rebrand it as oral systemic infection, and which communicates to the patient you have an infection in your mouth, but also is causing problems throughout the rest of your body. And I said we need to rebrand dental caries because cavities. I'm not sure what good term to use, but we need to rebrand dental caries because people just think cavities are normal and they're just a fact of life in modern man, and that's not the case. You can be decay-free, and it is. Maybe not a classic infection, but certainly it's something that maybe we could rebrand. So my take-home message for you tonight is Candida, yep, still a major player in dental caries. Make sure you document and you're looking carefully at when you restore. And I would, again, put in, you made the decision, you included the patient's caries risk whenever you make that decision. And then if you're going to make a decision based on caries risk, that means you've done a caries risk assessment, kind of as a necessity to know what their caries risk was. But I know that you guys are all here trying to help people. We're all trying to do our best and use sound clinical judgment. But I just want you to know that goalpost is moving. And those E1 and E2 lesions, start thinking remineralization. Start thinking non-restorative therapies. And actually, remineralization in my world is a restorative therapy. It's just not with a drill. It's restoring it, the enamel back with nanoparticles or whatever. And so we've got the non-restorative guidelines, silver diamine fluoride sealants, 5,000 part per million fluoride gel, et cetera. So, think about those guidelines. I showed you 3 different sources and more information about silver diamine fluoride. Maybe we're starting to understand how it works, starting to understand which lesions it works best on, and then also maybe think about it might stain immature enamel on just, newly erupting teeth. So those are kind of the big points, the big takeaways for you to take home tonight from this meeting. I really appreciate you guys spending your hour looking at this science. I hope that I made it interesting for you and then made you stop and think about what you're doing clinically and maybe modifying it as a result of that. At the end of the day, it's all about balance, having a balance your patients having a balance in their mouth so they don't have those prolonged periods of low pH. It's all about you having good balance in your life. And so I want to thank you again for spending this time with me. Kendall, I ran over about 4 or 5 minutes, but we have time for a few questions.
We definitely do have time for a few questions, which is a good thing. I think it's okay that you ran over. Like I said at the beginning, if anybody has to jump off, please, you are more than welcome to do that. We are going to run a little bit over time just because we've had so many questions coming in. Our chat has been blowing up. So thank you all for your engagement with us. We do want to make sure that we have some time to get questions answered because I know having this special time set aside live with Dr. Kutsch doesn't happen very often. So let's go ahead and answer some of these questions. So the first one that I wanted to ask was Dr. Ippish, and he had asked, if trying to remineralize an early lesion, overall, what would you say the protocol is?
There's a lot of so there's a lot of things to consider on this. And number one is, no matter how you go about it, with whatever your protocol is, understand that you're going to remineralize the outer 200 microns of that lesion. And pretty much that's it. But once you put that remineralized enamel skin now over that lesion, it's more resistant to future decay than the healthy enamel that's next to it. So if you have a white spot lesion and you remineralize it like that, if it's less than 200 microns thick, there's a chance that it'll disappear in the aesthetic zone if it's because you'll remineralize and fill in those voids that are there. But enamel teeth remineralize from the outside in always. It's physics. I've heard people brag about how we can remineralize from the inside out. Show me your science on that, because that defies the laws of physics. So you're remineralizing from the outside in always to a depth. The science is pretty consistent, about 200 microns. Now, having said that, if it's a white spot lesion that's in the aesthetic zone, you still got a white spot lesion. It's not going to decay, but understand that if you want to get rid of that, you've got to look at a different, you've got to either remove it with a drill or maybe infiltrate it with resin with something like the icon system or something. Now, if it's interproximal or anywhere else on a tooth, again, I would use this protocol. To remineralize that 4 times a year, I'm going to do a fluoride varnish on that patient. And then if it's cavitated, then you have the option of maybe you want to use silver diamine fluoride. Or if it's on a root surface that's starting to turn dark, you may want to, and depending on who the patient is and where it's at in the aesthetic zone, you might want to use silver diamine fluoride twice a year. I would recommend fluoride varnish 4 times a year, and then I would put them on a 5,000 part per million gel. And I want them to use that morning and night, throw their toothpaste away. We're going to the 5,000 stuff, and probably for long term. Think for the rest of your life kind of thing. And if it's interproximal, they really need to add floss to their equation in addition to the fluoride. So you could use a 0.05% fluoride rinse, but again, your best efforts would be done with a fluoride varnish and floss and a 5,000 part per million gel. And that should remineralize. I mean, if they do that twice a day, you can arrest those lesions. I hesitate now because of Rella's comments. I hesitate to use the word arrest. But you can theoretically arrest that, and as long as the surface isn't cavitated, again, you can provide remineralization. Certainly, I would want to use a product that has nano HA in it. I mean, that's how your body wants to remineralize. That's how I think that's the best way to do it based on what we know from how the mouth behaves, physiologically. So that would be my protocol. Great answer, or a great question, and a great answer. Yeah, thank you myself. It's a great question, but there's a lot of things. There's a lot of things that you need to consider when you think about, what are you trying to accomplish? Why are you doing it? Where is it at in the aesthetic zone? And then again, the patient's caries risk, certainly you want to work at mitigating their risk factors at the same time if you can. Great question. Thank you for asking that.
I'll validate you, Dr. Kutsch. That was also a good answer.
Thank you, Kendall.
You're welcome. So the next question I'm going to skip for just a minute. I'm going to come back to it. It's Jennifer's question. But I wanted to ask Dr. Reth's question since we're kind of on the track of fluoride and remineralization. He asked about a product that Elevate Oral Care makes. They also make the silver diamine fluoride. But he says Elevate Oral Care has a 2.5% fluoride varnish and states theirs is as effective as a normal 5%. Are you familiar with that? Do you have any comments about that product?
Yeah, actually, I know that the people from Believe It or Not. I know you're surprised. And I spoke to Kevin. I think we were at the Chicago Midwinter together when they were first releasing that product and that idea and data. I haven't read that study. I am familiar with the fact that product is out there. So I can't really give you an educated comment on that, so I probably shouldn't. So let's leave it at that. I mean, look at their science, look at their research, and try it if you want to. I've been using the 5,000, or the 5% for forever, and know that it works. So I'm comfortable continuing to do that. But again, I'd welcome looking at that research. Thank you for sharing that.
So I wanted to go back to Jennifer's question. She had a good one. What are your thoughts about placing chlorhexidine at the base of the prep?
So we're using chlorhexidine as a disinfectant?
It's what it sounded like. She said it was something that one of her doctors was doing and wanted to know if you had any thoughts about that.
I think there are better materials that you could use. Chlorhexidine, we know denatures protein. We're trying to bond to dentin. So one of the concerns is, are we denaturing the dentin that we're trying to create our hybrid layer with? Chlorhexidine also, there are other antimicrobial agents that are probably have a broader spectrum of activity. Certainly gluma, like I presented in the study tonight, if I were going to disinfect cavity preparations using a medicament like that, I'd go to gluma. That's got the best research, the longest term research, and so that's where I'd go. And if I were disinfecting, I would encourage dentists to look at Bella's protocol. I mean, her results are impressive. So I'd leave it at that.
Good, good. The last question that I believe we will take, unless we get more coming in, was from Dr. Reber. Does calcium buildup correlate with coronary artery disease?
Does calcium buildup, like I assume we're talking about calculus in the mouth. And does calculus build, so calcium buildup in the mouth, does that correlate to coronary artery disease? I think that's a really interesting question, and it's funny. It's like I've not seen any research. We look at periodontal disease, we look at pathogens, but we don't really. No, I have not seen a single research paper, and this has been actively studied, I think, since about 1997, that actually has asked that question and examined that. It's kind of like I laugh because I'm looking at the microbleeds in the brain and strep mutans, and my first question is, so did that correlate to how many cavities they had in their mouth, right? Did it correlate to their DMFT scores? So if I've got a patient that's got a lot of decay, I can tell them that, boy, this increases your risk for having a stroke. That's the kind of information I need, and they didn't even ask that question, and that's not been studied yet. So the same thing with the calculus buildup in the mouth, and would that physiologically, would that patient then have a pH in their body and their system that might lead to more calcification of plaque in the arteries? I've never seen a study that addressed that. It's a fascinating question. I'd love to see a study on it. So the answer is, I don't know.
Excellent. Okay. Well, there are lots more questions that we either answered during the presentation or that we will be following up on. So please, if we didn't get to your question, we look for a response within the next few days. We like to make sure everyone hears from us. You can obviously see on the screen, and I just posted in the notes box, Dr. Kutsch's email is there. He is great at responding to people directly. So if you do have additional questions, you are welcome to reach out to him there. I am going to switch the screen now and just talk about a few wrap-up items before I let you all go. We will be sending out a recording of the webinar tomorrow, so if you'd like to watch it again, if you want to share it with colleagues, which we highly encourage you to do, please feel free to do that. If you would like a copy of Dr. Kutsch's slides, you can download them. They're available in the Files to Download box. It's in the bottom of your screen, kind of in the middle. And the links are also still active if you're listening to this as a recording. The box right next to it that says how to download files will tell you how to do that. In addition to the slides, there are 6 research articles that Dr. Kutsch pulled out as being the ones that stand out to him and to what he shared with you tonight. So please feel free to download those if you want those. I also posted our risk assessment form and our product guide for Carie-Free. So we showed you that a few times throughout the presentation. If you are now convinced, if you were on the fence and you're now convinced that you would like to start implementing risk assessment with more of your patients, please feel free to use our form. We will send it to anyone to use. You can also email us and chat with us about that as well. If you're looking to learn more about the Carie-Free system, please visit the link. It's actually not an active link, but you can go to start.cariefree.com, which is found on your screen. feel free to give us a call. Believe it or not, we still like to talk to people on the good old-fashioned phone. So don't hesitate to reach out to us. We're here to support you and answer questions and help you out in any way that we can. And lastly, as always, we really appreciate your support. We welcome your feedback, so please let us know how you liked the webinar tonight, or let us know if there are topics that you're interested in us covering in the future. We want to make sure that this content is exciting and relevant to you guys. I would also like to let you know, so we, right now, the next webinar that we have on the calendar is in Q4, so it's in October. It is scheduled for October 8th, and we are going to do another guest-hosted webinar. So we're going to be inviting Dr. Amy Doneen from the Bale and Doneen Clinic up in Spokane, Washington, to come and speak with us. And Dr. Kutsch, did you have some thoughts that you wanted to kind of put out there for everyone about that webinar?
Oh man, if you have not seen Amy and Brad, we had them at the Oregon conference this year. We had them at the Rendezvous last year. Amy is my personal physician. They're amazing, and they are changing the world of cardiology. So if you have, I'm so excited about this webinar with Amy. So if you haven't had a chance to see them, make sure you register for this one. It is a don't miss. And I would give you this information as well. They wrote a book, Beat the Heart Attack Gene, and you can get it on Amazon. And I can't tell you how many of those I bought and given away to patients and friends and family. To start looking at, as we look at dental caries differently, they look at heart disease and strokes differently, and like I say, they're changing the world of medicine, and I can't thank them enough, and I'm excited about that webinar. So please join us.
Yeah, for sure. You'll be getting communication from us as the time gets closer. I know we're pretty far out now, but book your calendars because that's going to be a really exciting webinar. So that takes care of everything on my end. Dr. Kutsch, do you have any last-minute thoughts that you would like to leave with our participants?
Nope. I just want to say thank you one more time. I appreciate you spending, your time with me. I hope that you found tonight's webinar interesting and valuable, and I never take your time for granted, and so I always appreciate it. I just want to thank you.
Yes, thank you. Have a wonderful night, everyone.
Bye-bye.